I'm Joe Antos with the American Enterprise Institute. There's a clear connection between poverty and poor health outcomes. Low-income populations face a higher risk of disease and premature death. This is the result of many factors that extend beyond healthcare, and that's the important point. Lack of access to affordable housing, lack of access to healthy foods, quality education, reliable transportation, safe neighborhoods, meaningful employment. These and other social risk factors have a profound impact on the health of individuals and their communities. Today we will discuss one state's initiative to address the social determinants of health through its Medicaid program. Arkansas proposes to focus health and social service resources on 3 vulnerable groups of adults who enrolled in Medicaid when the state expanded eligibility under the Affordable Care Act. They are mothers with high-risk pregnancies, beneficiaries in rural counties with an emphasis on those with severe mental illness or substance abuse disorder, and young adults at risk of long-term poverty and poor health, which includes young people who've been severely disadvantaged their entire lives, or who may have been incarcerated, and of course the veterans population also faces serious health and social problems. The state is also proposing an alternative to a controversial work requirement that was struck down in federal court. Under the earlier policy, beneficiaries who did not participate in work, education, or other community engagement activities lost their Medicaid coverage. The new proposal allows them to retain coverage, but they would be shifted to a less desirable plan. The state, in proposing this, the state is reiterating its belief that work and other forms of self-improvement are integral to a healthy society. Of course, there's a lot more to the Arkansas proposal than I've just mentioned. The expert panel that we'll have starting at 10 o'clock will examine these and other aspects of the proposal, as well as broader questions about social determinants and the role of Medicaid. I hope you'll be able to stay for that discussion. So let me turn now to our keynote speaker, Arkansas Governor Asa Hutchinson. He is in his 2nd term as governor of Arkansas, and he was recently elected chair of the National Governors Association. His career includes 2 terms representing the 3rd Congressional District of Arkansas before he went on to direct the Drug Enforcement Administration and later became Undersecretary of Homeland Security. As governor, he has advanced a variety of initiatives to promote the health of his fellow Arkansans. As a chair of NGA, he's a prominent voice for bipartisan approaches as the country copes with the ongoing challenges, health challenges that we face, obviously not just COVID. I'm delighted to welcome Governor Hutchinson to AEI.
Thank you, Joe.
Thank you.
Thank you, Joe, and I want to express appreciation to the American Enterprise Institute for this opportunity to talk about healthcare policy and a very important national topic. It's good to be here, I must say, with a friendly audience. Since last week I had 6 town hall meetings in Arkansas on vaccination rates and COVID, and so it's nice to have a different topic. And also let me express appreciation to Joe Antos of AEI and Stuart Butler at Brookings for planning and leading this event. Now I've got to pick on them a little bit because Joe and Stuart have seen it all in terms of healthcare debate and policy. They have been engaged since the late 70s when HHS had a different name. It went by HEW at that time. They have seen the inter-party feud between President Carter and Senator Ted Kennedy on national health insurance. You fast forward and they watch the Hillary Care debate as it ran into a couple named Harry and Louise, and a skeptical public and Senate as well. They saw the health care policy dramatically change with the Affordable Care Act under President Obama. And now the debate continues as the Biden administration weighs the conflict between assuring access to health care and the rapidly escalating costs that drive inflation and the federal budget deficit. And so, as they say in the Farmers Insurance commercial, Joe and Stuart know a thing or two because they have seen a thing or two, and still there is more to come. And the future of healthcare is what brings me here today. But first, let me spend a little bit more time with the perspective of history. In April of 1977, when President Carter sent his healthcare legislation to the Congress, the U.S. spent $173 billion on health care, which more importantly is about 8% of the gross domestic product. Today, we spend $4 trillion on health care, which is nearly 18% of our gross domestic product. This increased investment raises one question: are the taxpayers getting their money's worth? And history also reminds us of the importance of employer-based insurance. At the end of World War II, employers began to offer health insurance coverage on a large scale to recruit workers when they could not offer higher wages. The decision during the Eisenhower administration to keep employer contributions for health insurance tax deductible was a key to keeping more Americans covered by health insurance. Today, employer-based health insurance is the largest source of health care for Americans. And this is an important point. And in my view, this is important, and the federal government should never be the sole provider of health care to Americans. If that happens, quality of health care in America will decline. Besides employer-sponsored health care, another source of health care for Americans is Medicare. The 65 million senior citizens and individuals with disabilities reliant on Medicare should not be forgotten as we look into the future. And specifically, we need to address the financial instability of the Medicare Hospital Insurance Trust Fund that is projected to be imbalanced in the coming years. In fact, the reality of the pending insolvency should be the highest concern because it is projected to be insolvent within the next 5 years. While focusing on COVID-19 pandemic is our top health concern, we must also be prepared to address the financial uncertainty of Medicare for our senior citizens. Our family members who depend upon Medicare are counting on leaders to set aside their political differences to build the needed coalitions and working groups to solve the trust fund shortfall. As a preacher once said, in terms of decisions of this life, there is a payday someday. And that message applies to Medicare if we don't solve its current financial shortfall. And the last area of debate is probably the most important, and that is the principles that we should follow in the healthcare policy arena. There are some in Congress who want to federalize our entire healthcare system under a grandiose plan controlled by left-leaning bureaucracy. Yes, their voices may be loud, but they must ultimately fail because the majority of Americans fundamentally know that there is a limit as to how much the federal government can take from the pockets of employers, workers, and consumers. The other side of the debate is what I favor. We must return to the principles of true market competition. We must return to the principles of individual liberty and responsibility and the power of consumer choice. These are the virtues that improve quality and lower cost. Solving the problem will require leadership to put the public interest ahead of our current political divide. And now let me focus on the reasons for my presentation today. Arkansas has submitted, as Joe mentioned, a Section 1115 demonstration waiver named the Arkansas Health and Opportunity for Me program. We are branding it under the name Our Home. Let me emphasize that this is not just another Medicaid waiver that seeks to add coverage or deliver health care in a slightly different way. Our proposal, our home, goes directly to the linkage between poverty and poor health outcomes, and in many instances, regretfully, premature death. Some background I should share with you is important as we look at this waiver application. And let's look at going back in Arkansas to 2013. Prior to 2013, Arkansas severely limited Medicaid coverage for able-bodied adults. In fact, it was the lowest cutoff for Medicaid eligibility in the nation. In 2013, a parent with a dependent child with income above 17% of the federal poverty level was not eligible for Medicaid in Arkansas. In Arkansas, that equates to an annual income of about $3,000 for a household of two. An able-bodied adult, less than 65 years of age, without a dependent child, had no pathway to Medicaid eligibility. But the good news is that in 2013, Arkansas made the decision to expand Medicaid coverage to the able-bodied adults who make less than 138% of the federal poverty level. And yes, that was an accepting of the Affordable Care Act premise that we ought to expand Medicaid to those, that new eligible population that is able-bodied and able to work. This decision increased health care coverage and led to a 12.3% drop in the state's uninsured rate. It went from 22.5% uninsured rate in 2013 to 10.2% in 2016. That is the second largest decline in the nation. When I became governor in 2015, there was a debate among our newly elected Republican legislature whether Arkansas should continue with the expanded coverage. I supported continuing that expanded coverage with some conservative reforms, and it was passed by the legislature, and it continues to today in a different form. That is the good news, the expanded coverage. But as Paul Harvey would say, now for the rest of the story. Despite the gains in health insurance coverage, Arkansas continues to struggle to improve its rankings in improved health outcomes. According to the most recently released America's Health Ranking Annual Report, Arkansas ranks 48th overall among the states in health outcomes. In other words, we have poor health. While improvements in several areas have been made, Arkansas has not kept pace as we should. Here is a central point, that coverage itself is not enough to achieve the improvements in health care status that the people of Arkansas expect and want to work for. And so we want a new approach. We want more for the money. We are asking our health plans to do more, our hospitals to do more, and our enrollees to do more as well. In addition to providing health care insurance, our home will focus on maternal health, mental health, and addiction services, and the improved delivery of health care in a very rural state. For example, we intend to concentrate on the health needs of women with high-risk pregnancies, young adults who still suffer from childhood traumas, and people with mental illnesses, too many of them who remain in the shadows and on the margins because of fear, discrimination, or the stigma of their illness. We cannot just wait for them to come through the door of the hospital or the doctor's offices. We must go out to them and meet them where they are in their life. I've had some experience recently with trying to improve the vaccination rate in Arkansas, and it is startling to see we are only looking at the vaccination rates in the counties. And I said, can you give me the city data? And you look at the city data, even in a rural county, but the city data might be 66% vaccination rate. But the overall county vaccination rate is 25%, which tells you the rural areas of that county has an extremely low vaccination rate. And so what that tells me is that they're not coming in to get their vaccination. You've got to go out, and that's what we're doing in Arkansas, and that applies to the delivery of health care services. we've got to do more. We've got to be where they live and meet them and the needs that they have. Our home creates 3 new types of community bridge organizations that we call Life 360 homes. One of those Life 360 homes is to serve women with high-risk pregnancies. Another one has a particular emphasis on serving people with behavioral health needs. And the final one is to serve young adults most at risk of long-term poverty. This could be the ex-offender population. It could be foster children that are aging out of the foster system, but they're struggling and trying to find their way in life and they need help. And each of these Life 360 homes will be anchored by a community hospital. Arkansas is very fortunate to have some very fine medical facilities. Many of these are faith-based. Many are small community hospitals that are struggling to provide the medical care needed in the community and to attract the providers, the medical physicians that are needed. Our home is a challenge and an invitation to our community hospitals to increase their services. And when you increase their services, you increase the flow of income to them as well. Their doors are open, and we invite them to open them even wider. They are mission-driven, and we invite them to expand their mission. But we're not asking them to expand their mission on their own. Our home proposes to pay hospitals to recruit and train coaches, recruit and train peer specialists, or to partner with other community organizations to engage individuals one-on-one. Many in rural areas have no access to behavioral health services because of a lack of licensed professionals. Our home will expand the pool of qualified mental health professionals and fill the gaps to better health outcomes to be developed in our rural America. Our home will also engage individuals to improve job skills and to be ready for work. While this waiver will not include a strict work requirement that most recently ran into trouble in the court system, we can incentivize education, work, and community service. Work and employment are shared values for our nation, and they are keys to ultimately improved health outcomes and to escape poverty. For example, a March 2016 paper from the Centers on Budget Policy Priorities, the authors state that, quote, adults in poverty are significantly better off if they get a job, work more hours, or receive a wage hike, end quote. The dignity of work is a shared core American value as expressed by the Center for American Progress. Quote, work itself is fundamental to how human beings realize their destiny in this world, end quote. The center goes on to say, work, whether a paid job or unpaid work in the home as a caregiver or in a volunteer capacity, is fundamental to human nature and its expression. This connection between work and human dignity lies at the core of progressive values. More recently and more appropriately, the American Enterprise Institute, in its April 2020 paper called Health and Poverty, the Case for Work, expresses a similar perspective. Quote, work is essential to health and well-being, especially for prime-age people who find themselves poor. By ignoring the importance of employment, government policies do a disservice to the people they purport to serve, end quote. And so we see that policy groups at both ends of the political spectrum agree that work is not just an American value, but it is a human need and purpose of life. Everyone also agrees that there can be a disincentive to work if the increase in income results in a reduction in benefits, the so-called Medicaid benefit cliff. One of the purposes of our home is to offer solutions to this benefit cliff. We don't want to incentivize anyone not to work or move up the income ladder. By using premiums, co-payments, and incentives to make Medicaid more closely resemble the private insurance market, our home will create a bridge from public insurance coverage over the benefit cliff and to private insurance coverage. Individuals who begin their coverage in Medicaid and increase their income, which we want them to do above the Medicaid eligibility limit, will be able to stay with the same plan, with the same benefits, and the same provider network. The individuals won't lose their doctor because their source of financial assistance has changed. That is what premium assistance under our Arkansas plan makes possible. Our home is also a challenge to the health insurance plans, not only to do more, but actually to define themselves in a different way, to be more. The nature of health insurance historically has been to provide access to care and protect against unforeseen, unpredictable financial cost. Our home challenges the health plans to provide incentives, to encourage members to do what is in their own health and economic interest. With this new mandate, the health plans will have a menu of incentive options for their members that will encourage healthy behavior, increase their employment, education, and training so they can lift themselves, the enrollees can lift themselves up to improved health and out of poverty. That is the objective. Now, there are two questions that might be raised to this initiative and the waiver application. One of them is this consistent with the purposes of Medicaid? And the answer is resoundingly yes. Since its beginning, Medicaid has been described as an anti-poverty program, but at its origin it served populations that were outside the workforce, the elderly, people with disability, children, and low-income mothers. In other words, Medicaid was reserved for different groups of individuals who at the time likely could not acquire insurance on their own because they were not employed or they were not considered to be employable. So the original Medicaid program made no reference to the newly eligible adult population under the Affordable Care Act, which was created because this group of people who are employable, but their low income was not originally qualified under the Medicaid program. In fact, the Affordable Care Act should be used as a means of helping low-income workers improve their health, increase their skills, and their work opportunities. So yes, this waiver is consistent with the purpose of Medicaid as a safety net and also to help people to move out of poverty. Now, the second question might be of more interest, and that is whether this waiver advances conservative principles. Again, it is conservative to let the states innovate and to recognize the unique challenges of each area of our great country. Because Medicaid is a grant to a state, each state participates in determining the purposes and objectives for its use. States must not be reduced as mere agents of the federal government and must be allowed to exercise a fair and real share in decision-making and innovation. And it is conservative also to use the private sector, as our home does, to do what government does not do well, to coordinate care, to be accountable for outcomes, and incentivize lifestyles that lead to improved health. And finally, it is conservative to use federal dollars in the most efficient way possible with oversight and accountability. Under our home, there will be quarterly program monitoring by a joint legislative executive oversight panel that will be important to keep the program on track. And so let me lead to a conclusion. And so the health care plan that we seek to build in Arkansas is both conservative and compassionate. It is both conservative and practical. It is both conservative and based upon common sense. It is my hope that the Biden administration will approve this innovative approach to health care and that conservatives will see it as a practical means to take an expansive federal program and overlay it with the efficiency of the private sector. That it will be understood as a plan to restructure a federal program in a way that provides flexibility to the states and reinforces the historic human values of work and responsibility. When we look to the future, we must fight to keep America strong and free. And it is easy to do that. But I remember the sign in the Oval Office when Ronald Reagan was president, and I had the privilege of serving as his United States attorney and to see him in the Oval Office. And that sign that was on his desk simply said, "It can be done." And so when we ask if we can keep America strong and free, the answer is very simple. It can be done. Thank you.
Thank you very
Joe.
much. Well, I'm sure not everybody got the same message that I got when the governor mentioned the famous insurance company ad. Are you saying that we have lived through a series of car crashes over the last 50 years? I think there's something to be said for that.
You're comparing car crashes to healthcare policy.
Indeed.
That's good.
Your last point about whether this is a conservative proposal, I think is an important one. And I think of it in terms of conservatism with a capital C and a small c. And I think the important conservative interpretation of this is the small c. It's what the average American thinks is right. It's what they would do if they had the opportunity. So I think that's something that Arkansas needs to convey to people in Washington. I think it's not well understood that there's a difference between politics and reality.
That's exactly right. And I'm a conservative. We're a conservative state, but conservatives cannot live and govern in a world that doesn't exist. And so, if we had to theoretically start from scratch and design our own healthcare system, conservatives would design something different than what we have right now. But we don't live in that world. And so the conservative approach is taking the real world and saying, what conservative principles can we apply to that? And that's what we've tried to do to have better outcome, being responsible financially, to being efficient with these federal dollars, to incentivize important values of work and responsibility, and to really look at the goal of moving people out of poverty rather than a permanent state of life.
Yeah. By the way, I just realized that I forgot one administrative matter, and this is really addressed to the online audience. We will have a period of time towards the end of our time with the governor for audience questions, and so people here in the audience, raise your hands. There will be a microphone. But if you're online, you want to raise a question, please either send an email to, and I'll give you the email address right now. It's cameron.tarbell@aei.org, cameron.tarbell@aei.org, or tweet #AskAEIHealth. And we will attempt to identify that you've actually sent us a question. Things are a lot harder the way we're doing it today. So having taken care of that, one of the aspects of the proposal is reliance on private insurance companies, which is Arkansas, I think, was the first state that in expanding their Medicaid eligibility, moved to private insurance companies that are fully qualified under the Affordable Care Act. So this is good coverage. It's expensive coverage. It's also heavily subsidized for low-income people by the federal government. Why did you go in that direction rather than move towards Medicaid managed care, which a lot of states have done?
Well, it's a perfect question, and sometimes it's hard to realize how different Arkansas' approach is. And again, this was, whenever it was adopted, we had a Democrat governor and we had a Republican legislature, and they looked at the time, and the Republican legislature actually drove the issue that we're better off and have a better outcome if we use the private insurance market, because it strengthens that. It's actually helped us to keep the pool of overall insurance premiums down because you had a broader pool of participation in it of people that were working even though that they were low income. So that was adopted, and there's been a lot of debate about whether we should shift back to a fee-for-service plan, but first of all, it would really undermine the stability of our rural hospitals, our healthcare system in Arkansas. They have better reimbursement rates that are under the commercial health insurance, and so it allows the providers to serve better in the rural hospitals and rural areas of our state. And then it allows you to have more reform, but it is more costly than a strict fee-for-service approach. And that's why we have to demand more of our insurance companies, more out of this program to have better health outcomes. If you're going to have the same poor health outcomes, then you might as well be in a fee-for-service model of traditional Medicaid expansion, but we can do it better. I think it works well in Arkansas, and this gives us opportunity to change things over the long term in terms of improved health. But we've got to ask more from our insurance companies that are providing the coverage, but they have to provide additional services and incentives.
Governor, can you expand a little bit on that? I mean, there are a lot of actors in this system: hospitals, insurance companies, potentially physicians, social service agencies in the state, and not to mention the patients, or I like to think of them as consumers, but we're talking about health now. What does do more? Can you give us some examples of what do more means?
Great. Well, for example, you have someone that is coming out of the foster care system, and they've aged out. They've got to make their way through life, and so they're qualify for Medicaid expansion and coverage, and so they're enrolled in a coverage insurance policy, and as part of that, they're going to be assigned to a Life 360 home to make sure they have the support that they need. Or it could be an ex-offender that comes out of prison that's assigned and where you'll have a hospital, probably in an urban area because that's where the ex-offender might be, and they're going to be contracting with perhaps a bridge faith-based organization that will help them to get a driver's license, that will assist them to make sure they get their medical appointments if they have any health issues, that they're addressed. And so it's affirmative help going to them, helping them get on the right track. It will be about the expectant moms, and we have, of course, very difficult birth rates, healthy outcomes on maternal care, and so we could save $140 million if we simply followed up and reduced those numbers of high-risk pregnancies that lead to bad health outcomes. And so you would have these high-risk expectant moms assigned to a community hospital. They will be followed up for 2 years with visits into the home, making sure that they have the support that they need in maternal care and with their child. So these are specific things that the hospitals can do in partnership with the coverage that they have.
Yeah, let me make a comment on that last point. It's an issue that I've been very concerned. A lot of people have been very concerned about, and that is the importance of a stable home life, reduction of acute crises for the infant, not just for the mother. I mean, this really starts in utero, but certainly the idea of having interventions that help mom do a better job of being a mom, I think is critically important, because this is, of course, when the baby's brain is developing, where behavioral patterns are established. And if you wait too long, then you've just pushed the problem further out to a point where we may not be capable of dealing with it anymore. So that's a little editorial comment.
I accept that. That's exactly right.
So the other thing that comes from your point here is that we're not just talking about healthcare, and we're not just talking about hospitals. We're talking about a broader array of social services, and I'm kind of curious what your view is of how this is going to work. The money's going to flow. Let's ignore everybody but hospitals. The hospitals are the big entities anyway in every state. So the money's going to flow to the hospitals. Instead of getting the low traditional Medicaid rates, they're going to get something approaching a commercial rate through these ACA exchange plans. That gives them some extra dollars. But especially in rural hospitals, they're may not look at that money as a windfall. They're going to say, we've been struggling all along. What are we going to do now?
Exactly, and that's why there will be a separate flow of funds to that community hospital that will allow them to hire peer specialists, that will increase their provider network, that will have the life coaches that can go out to the expectant mom or to a person in the community that has drug addiction challenges that need that type of long-term care assistance or mental health counseling. And so they're going to have not just their usual reimbursements for the care they provide in terms of the emergency room or surgeries, but they will have a separate responsibility under our Life 360 homes to carry out these other missions. And you say, well, where is that money going to come from? Well, it's going to have to come from the savings of money for long-term from reducing some of these adverse health consequences. And as I said, and just one of them is the cost of low birth weight babies and premature births is $140 million per year. So if we can make progress on those outcomes, save dollars, that's where we will have, the additional ability to support those Life 360 homes in the hospitals.
Thank you. We're actually beginning to run short of time, so I think we should turn to the audience for questions. And since I can actually see you, let's start with the audience here at AEI. Please raise your hands, and someone will ideally come with a microphone, I hope.
You got a question over here?
Yeah, here's a gentleman here.
Thank you. I'm Bill Arnone with the National Academy of Social Insurance. First of all, congratulations on becoming the new head of the National Governors Association. Hope you use that platform to expound. Could you talk about what your new Medicaid program impact would be on long-term services and supports, either institutional or home-based community supports?
Well, make sure I understand. Long-term
care, long-term service support, but most for older people, either in nursing homes or home-based services. Would your plan have an impact on those services to the elderly?
Well, the elderly should be on the Medicare side, and so this addresses the Medicaid. Of course, in the long-term care facilities, you're right. I mean, that's covered by Medicaid, and so that's the traditional fee-for-service provisions. I think the impact would be in expanding the ability and the mission of home healthcare services, because that's part of where they can contract with the local hospital to do follow-up care, to do affirmative care in the homes, to have improved health outcomes. And so I see that probably as the biggest impact in terms of some of the home health agencies.
Yeah, Bill, I think you're also making the point that people would rather have some help at home rather than move to an institutional setting. Absolutely true. And that help doesn't have to be medical. Oftentimes, it's someone who keeps me, I'm going to speak now personally, from climbing on that ladder to reach that shelf that I can't reach. I could probably use the help now.
Yeah, no.
We have any others? Yes, ma'am.
Hi, thanks for having this event. My name is Sandia Rahman. I'm a reporter with CQ Roll Call, and I was curious if you could talk a little bit more about the work incentive and how the coverage would change if someone were able to work or was not able to fulfill that requirement. And kind of additionally, if you are concerned that given the previous work incentive was blocked in court, whether there might be some issues with this one. Thanks.
Well, the previous one was a work requirement that required community engagement or education, and it was a requirement for coverage, and that's what the court struck down, and so that hasn't been in place. We continue to try to push community engagement, but this takes it, from a punitive standpoint but into an incentive area, and it could be, of course, we're looking to the insurance companies to model what some of their incentives would be. It could be that if somebody is able-bodied and they are low income, they can have an incentive to go and get higher skill job training, and they got their coverage for that, but they could be incentivized with a lower discount or something if they continue to go up for job applications, go to a job fair, or go into a higher skill environment. And so that's one of the incentives that could be done. It could also be through some of the community support organizations and the Life 360 homes that they follow up and say, well, what you need is, a higher level of employment. They might not have a vehicle, and so the community organization will help them to get that. So these are positive supports as well as incentives that could be offered. And then you ask about, well, what's the consequences? If somebody, and that's why we ask more of our enrollees, that to have this higher level of coverage with a private insurance, we do expect to conform to the requirements of the insurance policy, and we'll still have to develop the rules. This is a couple of years later down the road, but they could go back to a fee-for-service model if they did not fulfill the obligations that they had. And so previously they lost coverage under the old work requirement. Now they would not lose coverage, and that's the key point. They would maintain coverage. It would just be in a different model, and again, the specifics of that would have to be adopted through rules down the road.
Okay, so I know that we got a question from someone from Australia, which I think this is a first for any event I've ever been.
I like it.
And I am going to broadly interpret this question because it was pretty technical. I think that the general question was, what in the plan will encourage people to adopt healthier living styles, better eating, more exercise, that sort of thing? How do we break through that barrier, especially given, I guess it's some people call it 20-20-20, the 20 pounds that many people have gained over the last year and a half?
Well, it's a great question, and thank our friends from Australia for the question. But right now, insurance companies are very accustomed to providing incentives or discounts for annual checkups or for certain health responsibilities that the enrollee might be required to do. But in addition to that, of course, you're going to have a more affirmative outreach here, because as I point out, if you're in the rural community and you're not getting vaccinated, that could mean a number of things. You're busy, you're putting it off, and that's their approach to health care. So we want responsibility on their part, but we also want to make it as accessible as possible. And so they might not know what is needed. And so you're going to have a coach, you're going to have a peer specialist to say, you need to be in addiction counseling, and this is where you can get it. you need to have support here, or you need to exercise and point them in the right direction. And so and that's what's unique here. You have both traditional incentives as well as a more affirmative approach through our Life 360 homes.
Okay, great. Well, I think unless there's another question from the audience. Yes, please.
Thanks so much for being here, Governor. My name is Chelsea Ceruso. I'm a reporter with U.S. News. As a follow-up to the question about the alternative to the work requirement and the changes in this waiver, my question for you is, do you think CMS will approve this waiver? Have you had conversations with them at all?
I have, and I wanted to introduce Dennis Smith here, who's our senior healthcare advisor at our Department of Human Services, and he and my team met with our HHS folks here in Washington as well as OMB yesterday. And of course, at this point, our waiver was just filed like Tuesday. They say, you expect us to have already read it? So, but I wanted to stress to them the importance of this review, and it's important to me. Now, it's obvious to me that they're going to look to make sure that we don't have something like we had before that the Biden administration was clearly opposed to, which was a strict work requirement. But as they look at it, and as I've explained, the objection is they don't want people losing health coverage. And so what we're requesting is a plan that does not have a consequence of individuals on the expanded Medicaid from losing coverage. And I think with that, they'll have confidence in it. And all of the areas of this we've put together, but it's picked different items that have historically been supported. We're just putting it together in a unique and innovative package that'll work for Arkansas. Okay, well, I want to thank everyone for attending this part of the event. I especially wanted to thank the governor for a fascinating discussion of a fascinating proposal. We'll see what happens. I'm sure, having been there myself, I'm sure that there will be plenty of technical questions. And Dennis, good luck.
Thank you, Joe. Thank you. Thank you, everyone.
So thank you. We all thank the governor. And I have a few technical questions technical issues to raise with the audience, but let's excuse the governor who has another meeting to go to. Okay, thank you very much. Watch your step. I want to thank everyone who hung on, who have hung on during the intermission while we shifted to this virtual panel. And I want to remind people that the only way we can receive questions, and we welcome questions from the audience, would be through either an email to cameron.tarbell@aei.org or through Twitter, #AskAEIHealth. So we're looking forward to your questions, and ideally, we will never do this again. Okay, so let me start off by introducing the panel, and then I want to set the stage a little bit with regard to some of the major provisions of the Arkansas proposal. But let's start. And since there's never any real order here, I'll start with Kosali Simon. Kosali is the Herman B. Wells Endowed Professor and Associate Vice Provost for Health Services at Indiana University. She's also, in her spare time, editor of 2 major academic journals. She writes a lot of technical articles, and she's a member of the National Academy of Sciences, Engineering and Medicine. I think of it as the National Academy's Roundtable on Population Health Improvement. Her research focuses on the impact of health insurance reform on healthcare and labor market outcomes. Next, we have Randy Pate. He's the founder of Randolph Pate Associates, which is a management and strategic consulting firm in Washington. Randy was deputy administrator and director of the Center for Consumer Information and Insurance Oversight at CMS, the Centers for Medicare and Medicaid Services, for most of the past 4 years. Under Randy's leadership, CMS approved 15 state innovation waivers and worked with states to develop significant new flexibilities under the Affordable Care Act. And prior to CMS, he was a senior executive with a major health insurer and has done a lot of other things with healthcare and health policy. And then finally, Stuart Butler, my partner in crime here on this event. If there are any mistakes, Stuart, I'm going to blame you. Anyway, Stuart is a senior fellow at the Brookings Institution. For many years, he was vice president for domestic and economic policy studies at the Heritage Foundation. I would argue, by the way, that his move to Brookings represents not some change in Stuart's philosophy, but rather a consistency of his philosophy and a belief that bipartisanship is a virtue rather than a fault. And I agree with that. He's well known for his role in the debate over health reform and policy solutions based on individual choice, state innovation, market competition, and social determinants of health. In addition, Stuart has been an advisor to the National Academy of Medicine's Culture of Health program, and he's on the board of Mary's Center, which is a community health center serving the Washington metropolitan area. So I'll turn to you folks in just a second, but let me just kind of set the scene here by summarizing the major components of Arkansas's proposal. Can I have the slide, please? I hope to see the slide. Are you there? Okay, well, okay, this is something, again, that we ideally will never do again at an AEI event. Okay, so here's the proposal. There's a lot of aspects to what Arkansas is presenting to CMS for approval that we're not going to get into, but these are kind of some of the big features, at least from what I could see. So, if you were watching the governor speech, he addressed most of these issues, but it went by pretty quickly. So we're gonna kind of dig into most of these issues. A big aspect of this is something called premium assistance. And what that means is that instead of enrolling the expansion population, the expansion population under the ACA is by and large adults. I'm not sure for Arkansas what the maximum income level was for coverage under Medicaid before the ACA, but this expands eligibility for adults to 138% of the federal poverty line. And as the governor said, that substantially reduced the uninsurance rate in Arkansas. So that was a big change. These are people, again, they're adults, probably largely male. They're not being enrolled in traditional Medicaid. They're not being enrolled in a fee-for-service program. They are being enrolled in private insurance plans. Now, so that's one, I think, difference between Arkansas's expansion and a lot of other states that expanded their Medicaid programs. Second point, the incentive to encourage work, education, and community engagement. The governor addressed that in the talk. It's a big change from the controversial proposal or controversial provision that they had that was a true work requirement. This is an incentive. Third big issue or big provision is that instead of throwing people off of Medicaid coverage altogether, if enrollees fail to meet these work requirement incentives or work incentives, then they don't lose coverage. They fall back to fee-for-service Medicaid, and of course they can go back to a better plan under the premium assistance program if they're willing to kind of abide by the rules. There's an encouragement there rather than a penalty, which is a big change. Next thing is the targeted intervention and care coordination to address social determinants of health. The governor covered that very well. We're going to be talking quite a bit about how that may or may not work. Then he also mentioned accountability, and accountability is a big factor here. One of the points that I think Arkansas and others have made is that it's very hard to compare how well different state Medicaid programs are doing in actually improving population health. We don't have good measures. We don't have standard measures. I think most programs are struggling with how to do something rather than struggling with how to measure what they're doing. But this is something that I think Arkansas is trying to make a step forward on. And then finally, and this is again something that came up earlier, the higher commercial payment rates are intended to support health system improvements. So anyway, this is the bare outline. We can drop the slide now, please. And so let's turn to the panel. Slide gone, please. Okay, great. And let's start with everyone's sort of top line reaction to the proposal. It could be, what do you see as most promising? It could be, what do you see as most problematic about the proposal? Or it could, address anything you want, including where you see Medicaid's role with regard to these broader social issues that so deeply affect healthcare for low-income people. And who wants to start? We did not negotiate that, so I'm going to pick on Cosley.
Happy to. Thank you, John. Thank you, AEI, for organizing this event, because I think, as the governor said, Medicaid is an extremely important program when we're thinking about health of vulnerable populations and social determinants. And to put that in perspective, he explained how Medicaid has grown to be now far larger than Medicare, with 81 million people enrolled as of early this year in Medicaid and CHIP, compared to 61 or so million in Medicare. It's really cannot be overstated how important the design of Medicaid can be in addressing social determinants and their impact on health. So second is that Medicaid is more than just health insurance. In fact, Medicaid is not textbook health insurance, where we pay an actuarially fair premium for covered services. We are using the design of this program in ways that have to be very delicately thought through. So that's why there is so much discussion about, so exactly how is it? It's not as simple as in textbook insurance, where we're thinking about moral hazard or incentives, premiums, copays being used. So, but really kudos to states that have figured out a way to expand when their neighboring states have not, and have taken advantage of that opportunity in the Affordable Care Act to extend coverage to hundreds of thousands of residents who are among the poorest in the state. So now the question is not really about, wanting to have ways that insurance is designed to encourage what we all agree are benefits, being connected to work and education, improving economic opportunity. There's no question across the, any political spectrum, those are really important. I think that the devil is really in the details, where we're having these discussions of, is this the right approach, is to see is because we don't, even right now, the application that's in front of the administration is more of a framework, as the state has said. The details of exactly how are we going to measure compliance? What does it mean? Is it going to be a work requirement? Is it going to be work that satisfy the incentives? Or is it, in some of the literature discussing this waiver, it could even be a visit to a physician is going to satisfy this requirement. So these are the questions we're grappling with, I think. So thanks again.
Yeah, I think that's a really good point. Thank you, Coastaly. Randy, could I call on you?
Sure. Thank you, Joe, and thank you to AEI for hosting today. I thought it was a great announcement earlier this week. I think the waiver approach is a step in the right direction, and I think it really demonstrates the importance of state flexibility in crafting solutions that really best suit the state residents and the state market. One key lesson that I learned during my time at CMS is that all states are different, and therefore the solutions that the federal government offers states should be flexible for that very reason. So I think, the plan obviously shows a strong preference for private coverage. It's going to give people a choice between private coverage and public. We'll see which one they like better. I think about what if it was my family member, that was in this situation, what type of coverage would I want them to have? And I will just say, as a small businessman, I'm enrolled in an exchange plan myself with an HSA, of course. Other thoughts, cost is obviously a concern when you compare the cost of, providing for someone through Medicaid versus, private coverage. But, the difference in provider reimbursement rates, just like the governor said, between Medicaid and private insurance really explains this cost difference. Private plans offer really better access to care, more robust networks. And as the governor said, these higher reimbursement rates can really allow rural hospitals in some situations to even keep their doors open. So I think that's an important point. During the Trump administration, we championed state flexibility in many areas, including through 1115 and 1332 waivers at CMS. In just my area, in the individual and small group markets, we again approved 15 of the Section 1332 state innovation waivers that waived ACA provisions, including reinsurance programs for states that lowered premiums in their individual market by double-digit percentage points. We also approved Georgia's Section 1332 waiver, which is kind of under challenge right now. But the goal there was to replace the legacy, healthcare.gov health insurance exchange with a robust private sector competition model through web brokers. So, I think, I'm a big fan of state flexibility. Other thoughts, when you look at it, 60% of non-disabled working age Medicaid recipients are already working, and 8 in 10 Medicaid recipients live in families with at least one worker that's in the household. So, in light of that, are there ways to strengthen the connection between employment and health insurance? And as the governor said, if we had to create a healthcare system all over again, we probably would have done something different than the employer-based system. And I would say that, to expand this connection, it doesn't have to be through a traditional group health plan, with all the administrative costs and lack of choice for the employee. Employers can use something called an ICHRA, an individual coverage HRA, which is something that I worked on in the Trump administration, that allows employers to provide tax advantage money to employees to buy coverage in the individual market. And I think states like Arkansas can look at providing incentives to employers, particularly small businesses, to get them to provide coverage to their employees through ICHRAs. And I think that can actually help people stay out of Medicaid altogether. Just real quick, some of the coordination services that he mentioned around mental health counseling and the Life 360 homes. I know Dr. Butler will get into this, but it really reminded me of the ability for states to leverage waivers to deliver, more efficient coordinated care, and hopefully to reap savings and share savings with the federal government. So I think it's real important for states to take advantage of these flexibilities. I hope we can get into some of these ideas in more detail.
Okay, great. And then Stuart?
Well, thank you, Joe, and thank you, AEI, for doing this. I think it's a very important session. And let me just begin by saying I think waivers are really a very important component of thinking about healthcare. Waivers allow a lot of experimentation around a common goal. You take chances, you try things. just like AI is trying some different approaches to running a meeting here. So it's very important to do that, to learn. And we've certainly seen that in Arkansas before. Of course, you know, the previous governor of Arkansas, Bill Clinton, together with the Reagan administration, was very important in using waivers to experiment with better welfare reform. So the waivers themselves, I think, are really important. And as a tool, they allow states to explore approaches that reflect their particular philosophies and learn from what they've done, and to really tailor the approach to what's the strengths of that state. And so here, as the governor said, we have an essentially conservative approach that is built to achieve common goals in terms of what we're trying to do in this country, and is built on what we know. And I think there are 3 or 4 things about it that are particularly important. One is the first thing that you raised, the use of premium assistance. I think that allows us to think about a lot of possibilities in the future, and maybe addressing our late friend Uwe Reinhardt's common description of the American healthcare system, in inverted commas, where he said it depends on, you know, how poor you are, whether you're employed, how old you are. It's a totally different system for each one. And premium assistance allows us, I think, to gravitate slowly towards a system where people can choose the coverage they want, and irrespective of whether they fall below a certain income level or employed and so on, could have the same physicians, the same plans. That's a really important element, I think, of what we're seeing experimented with here. Secondly, this focus on the most expensive people with chronic conditions, most at risk people, is exactly the right thing to do. Willie Sutton said, you know, you rob banks because that's where the money is. Well, I think you focus on these populations because that's where the cost and the need is. And so I think we're seeing Arkansas, like North Carolina in its waivers, saying, let's look at people with really chronic conditions. And turning to hospitals as the sort of generator of coordinated services, not just medical services, is intriguing, and is, I think, an important development. I'm a little bit of a skeptic about hospitals as the focus, the hub of these kinds of activities, but I'm absolutely willing to be convinced. And I think that the history of Arkansas's community hospitals and faith-based hospitals might allow a more successful outcome using hospitals as the locus than maybe we've seen in other states. But I certainly hope that Arkansas also experiments with looking at things like federally qualified health centers and other hubs as well. But I think that's really important, that notion of looking at social determinants of health, what's going on with people's lives, and coordinating. Coordinating is very challenging, and we'll probably get into that. And then the third point I'll make quickly is that I do think that what they're doing in Arkansas, assuming it goes into place, could be a way forward, a model for other states that so far have refused to expand traditional Medicaid, the 12 states that have done that. I think they're going to be looking at this a lot, because I think it's a way of moving forward under Medicaid in a different fashion than most traditional views of Medicaid should look like, which is, of course, great concern to a lot of more conservative states. So I do think that there's a model here that might induce other states, if it's successful, to say, well, we'll hold our nose and we'll expand Medicaid, but we're going to do it on a basis of private plans in this way. And the last thing I'll just say quickly is, I really hope the Biden administration agrees to this waiver. If you are an administration that truly believes in encouraging bipartisan approaches and finding the best way, if you like, what the science shows as an experience shows, then they ought to approve this waiver, even if they don't agree with elements of it. And I go back to under the first Bush administration, I well remember when Gail Walensky, our friend, was running the equivalent of CMS then. They approved a waiver for Oregon that basically rationed care according to efficiency of outcomes. They held their nose and and said, this is something that ought to be tried, whether we agree with it or not, because it will improve our knowledge. And I really hope that, I think the way this is designed should be very approvable by this administration. And I really hope they go ahead and they, examine it carefully, and it would be a good experiment for other states to look at.
Thank you, Stuart. Thank you, Kosali and Randy. These are really good comments. I assume that we'll be talking about this for weeks and months to come, but we're going to have to try to keep myself under control. I have a hard time with that. I also had a reaction, kind of along the same lines that have been said in one way or another by everyone here. This is very much an experiment. It's not just an experiment for the state. It's an experiment for the country, we need to foster true experiments. I think they may be more possible in the Medicaid program than in Medicare, partly because Medicaid is a federal state responsibility, and states are supposed to be the implementers. So there's more likely to be a willingness to try things that weren't invented, 5 blocks from here. In the case of Medicare, I think, at least for much of the last, well, I don't want to impugn my own reputation, but for quite a long time, the idea that we would let providers or other entities that interact with the Medicare program come up with a new idea and try things their own way has been largely lacking. Medicare demonstration projects tend to be driven top down, and they haven't been as successful as they could be. And I think partly it's because it's not just from state to state conditions are different, but also from place to place, from provider to provider, from health system to system. There are strengths and weaknesses that really can't be easily taken account of if you're trying to do things centrally. So I think that's a really important point. The other reaction that I have relates to my long regulatory experience in the state of Maryland. This is a confession for those of you who don't know me, but even though I'm a free market kind of a guy, I have been on the state regulatory commission that has set hospital payment rates for a total of coming on, over a decade. I don't want to admit how old I am. And I can tell you that in Maryland, we are trying to do some things that address social determinants of health. But we are hamstrung by the fact that we only have the ability to work directly through hospitals. We can provide financial incentives. We can provide what are essentially financial penalties, but we can't really get coordination if it's not there, if it's not developed by the health system between physicians, other providers, and the hospitals, and social service agencies, including the state Medicaid department, by the way. We just can't get that cooperation unless there's great willingness, and that's very hard to come by. And I think this is something that Arkansas will be experiencing, probably has experienced, but this is something that's going to be a real challenge for everybody. The benefit that I think these demonstration projects have is that there's an opportunity to learn from mistakes. Mm-hmm. I think you're more likely to learn from mistakes than to learn from successes. Mistakes make you reassess. Successes make you think that you really figured it out. And by the way, I think generally we haven't. We just got lucky. Okay, so with that, with my usual positive view on spin on things, let's move on to some issues. And I think maybe we could start with kind of the role of private plans. Randy, in particular, raised this. And a point that I don't think actually came out very well. Why did the state enroll the expansion population in private plans that operate under the ACA exchanges? And part of the answer is that there's some money involved because the subsidies are quite generous for the lowest income people in the exchanges. Part of the answer is that there's an opportunity to bridge what the governor referred to as the Medicaid coverage gap, to make that transition as low-income people, do better economically, financially, as their income rises. If you're in Medicare, in Medicaid, once your family income rises above a certain point, you're out, and you might have a job that doesn't offer health insurance. Very likely, in fact, because it's going to be a lower scale job. But the other factor, which I only learned about yesterday, is that until possibly this year, but certainly over the years, there has not been a health plan that has been willing to offer managed care for Medicaid beneficiaries. There was no option for Medicaid managed care. The state essentially contracted with the Blue Cross plan and paid fee-for-service rates. Okay, so that's not a question, that's an observation. But maybe we could just have a little discussion about how we see the operation of private plans under this proposal. And in particular, an issue that occurs to me is whether private plans are really willing and able to meet the very likely greater health needs and greater social needs of the Medicaid expansion population.
So, Joe, maybe I could just kick this off and then, let others chime in. But when you were talking about, the role of private plans and sort of managing costs and coordinated care, I would say from my experience, I think there are some that are better at it than others in the individual market, and I think it depends, widely on the carrier. So you have some carriers that, like Centene, for example, that is in Arkansas. They provide Medicaid managed care in a number of states, and they are really focused on that population. This churn population, when you talk about 100% up to 250% of federal poverty. And I would say some of the other carriers, on the other hand, are coming from more of a group market mentality. And we saw sort of how that played out early in the market, where they aren't thinking as much around the special needs of this population. They're thinking more in terms of, traditional group benefits and how do you sort of attract employees, from the employer perspective. So I think they're learning over time. They've gotten much, much better. The plans have in terms of understanding this population. Now, in states that haven't expanded Medicaid, that you're looking at, people that are 100% of federal poverty and above are eligible for exchange coverage. Now, we don't necessarily know what the folks below 100% in that Medicaid gap population the governor was talking about. They may have some higher healthcare costs, but I think generally carriers are pretty comfortable with that 100% federal poverty and up, and I think they're getting better at managing those costs.
Thank you.
I would just add, I think it's always going to be a challenge to have really effective coordinated care, especially with non-medical services or social services under a fee-for-service kind of arrangement. It's just not it's not an ideal business model for a fee-for-service or organization of any kind. So I do hope that there's, as part of this waiver, a bit more experimentation, with Centene and maybe other managed care plans in terms of how they build in social services and see that as an integral part of their business model. And it's worth looking at some other states and other plans, I think, to give some guidance on that. If you look at something like CareSource, which is in Ohio and in Georgia, they provide employment services to people. They help people get their GED and so on, because they know that there's a connection between, as the governor said, work, in education, and better health. And better health means lower costs to the managed care company. They also have a dilemma, which maybe ultimately Arkansas would have to deal with, which is if you're too good at improving the economic condition of your enrollees, they cease to be eligible for Medicaid coverage. So you end up with all the costs as a plan, and then you don't get the benefit, if you like, of reduced enrollee costs. So I think there's a lot. I think it was Casale who said, the devil is in the details. I think it's very important within this general experimentation in the state to really look at this issue of the hub and the role of managed care and hospitals and so on. There's going to be a lot of important learning from trying those things out. And as you said, Joe, some of them won't work out successfully. They won't harm people, but you won't get the costs savings that you maybe wanted. But that's how we learn. It's exactly how we learn. And it's important to import ideas and learn from experiments in other states to graft onto this basic waiver. I hope that's what they do, assuming they get the approval.
I'm really glad we're talking about this way of learning from what states do, because this way of going into the exchange as opposed to Medicaid managed care are just two different ways of engaging the private sector in delivering public benefits. And this is definitely the pattern we're seeing. But we haven't seen an understanding of these as two different options. And so one thing I would be really curious to know is what is different about Arkansas that there isn't this managed care Medicaid option? Is there something that's different? Because in lots of other states, that is the way that private companies, like we've mentioned, I was going to mention CareSource too, because it's just so many innovative things that CareSource and companies like that are trying in social determinant spaces, which maybe an alternative states look at is it's going to cost money no matter what, right? Provider payments have to be higher in order to go beyond the Medicaid fee-for-service low payments and the type of access we know is an issue there. But is it, what's better for a state to put, and for the federal government because of the match, to put money into Medicaid managed care or into marketplaces? And many times it's the same insurance companies that are being successful in both, because it's knowledge about how to manage the health of vulnerable populations that make them effective in both cases. But is there something institutionally very different? And so what should states look at as these options?
Well, I have a speculation about that, and maybe Randy would have a comment as well, at least about my speculation. I believe that the real problem traditionally in Arkansas is it's a poor state. It's not just a poor state for the Medicaid population, it's a poor state overall. They don't have a robust, or have not had a robust private insurance market, from what I can tell. They fall below where higher income states are in terms of employer coverage as well. So I think it's just a lousy insurance market from a commercial standpoint, not so much from a Medicaid standpoint. But are you going to invest the money to build out a network and do all the things that you have to do to establish yourself in a new state? I think traditionally Arkansas hasn't been a good market. What's your reaction to that, Randy?
Yeah, I think that's right. And when you look at going to a capitation system, and you've got folks with a lot of high healthcare costs in the Medicaid population, obviously that's the risk that the insurance company is going to take on is something that they look at. Before this webinar, I actually looked it up, and I think there are 4 health insurance companies offering plans in the individual market in Arkansas, which is actually not too bad for a smaller state. So they do have some competition. There's nowhere that is that only has one carrier. No county just has one carrier offering coverage. So that's a good thing in terms of competition. But I think, I think that's where a waiver like this comes in. Will this attract more competitors into the individual market if they see they can come in and there's a more sustainable risk pool? You got more more people to cover. In a state that doesn't have a ton of population, that can be a really important decision point for carriers looking to come into the market or expand.
Yeah. Yeah, this also raises the issue about to what extent the Medicaid expansion implemented this way helped to, in essence, stabilize or improve the vitality of the individual insurance market. I think that's maybe likely. It is true that on average, Medicaid beneficiaries use more health care, but the people who were brought in under the expansion were largely adults, and were, I think, largely not the folks who need intensive health services. They were just left out of insurance altogether, because if you get sick enough, then you end up somewhere. So I think this was probably a somewhat healthier than average Arkansas Medicaid population, and that may have contributed to a stabilization of the overall private market that might have helped. Centene, I learned yesterday that Centene is definitely pushing forward, and a few other plans as well are looking closely at what they can do. And I think that's going to be contingent on the waiver, frankly. Okay, so maybe we could let's see. We should move on to something else here. What time do we have? Let's see. Work requirements. Okay, so work requirements. This is really something. One of the things that didn't come up in our discussion with the governor was just what a disaster the work requirement provision was that Arkansas actually did implement for a while. It was halted by a federal court. There was a mechanical issue, and then there was the question that is maybe more of a policy issue of are work requirements consistent with the goals of the Medicaid program. The mechanical issue was pretty disturbing, really, and it does tell you something about generally the problems of instituting really any new idea that involves active beneficiary involvement and where you want to collect information. Basically, what happened was that the population that had to satisfy the work requirement or lose their coverage had a great deal of difficulty telling the state that they were, in fact, fulfilling the requirements. Their employers were too busy. The employers couldn't take time to fill out forms. There was a requirement to submit information online. These are people who did not have good internet access. They were probably working when you could go to the public library or doing something else. They basically had a great deal of difficulty mechanically, and a lot of these people, this was a whole new idea. They'd never had to deal with this sort of thing, and they really weren't equipped to do it. Even if they could have internet access, how do you answer this question? How do you provide evidence that you're doing activities that meet that requirement so that you can hold on to your coverage? That's the mechanical aspect. The policy aspect is how strong can the penalty be to be consistent, to encourage in a vigorous way people to engage in activities that they will benefit from over the long term, without losing sight of the fact that the whole point of Medicaid is to provide assistance to needy people who don't have other alternatives for healthcare and a bunch of other services as well. So maybe we could have a little discussion about that. Where's the dividing line?
I think that, I believe that Arkansas took a wrong turn with its punitive approach earlier. We saw the results of that. We saw people actually losing health care and so on. And I think it didn't recognize the kinds of things you mentioned, Joe, just the practicalities of it for a lot of people. A lot of people, reasons why people don't work, and sometimes it's because they can't get to work, and there's all sorts of things. So I think the general approach they are here, which is recognizing that the way to get people into the workforce and moving up the economic ladder is a mixture of carrots and working with intermediaries, with people who are close to the individual's concerns. So I think the community hospitals are important, but I think also even more important are the opportunity in Arkansas to work with trusted intermediaries, with the churches, with community organizations, and so on. My experience has been that that's the route forward to get people to link together healthcare and the other things in their lives that contribute to better health, like housing and health and transportation, education, and so on. And I think the experience elsewhere absolutely underscores that. So I really hope that they build on what the governor talked about, the coaches associated with hospitals, because coaches are not just there to say, sign up here and there. It's a warm handoff. They help, they work with people. They're trusted, ideally. Maybe the governor or his staff should pop up to Harlem, New York, and look at Community Health Works, which uses coaches from the community, known by the people, to not only coordinate their healthcare, but make sure they get involved with the steps that will get them into the workforce and into better education for their kids and so on. Those trusted local coaches are the key to that. If they might also pop by and see Mary Center that you mentioned, because Mary Center is an FQHC, a local clinic, again, it's close to the community. It combines social service. We have a large social service internally, and also lots of links with other social service agencies. We're co-located in several places where early childhood schools and so on. That's how this is going to work. That's what's successful, not hitting people with a stick and saying, if you don't do these things yourself and figure it all out yourself, we're going to drop your health coverage. That was not the way to go. And I think what they're doing now absolutely learns from that. And they're going to really have to build up this coordination, including at the government level. Again, they should pop over and go to Maryland and look at the local management boards at the county level, designed specifically to coordinate the government entities and the private entities to improve people's lives. The examples are out there. With this waiver, they can import them into Arkansas and give them an Arkansas twist, if you like. But that's the way to go. It's a very exciting waiver. It really is. I believe it could be extremely important in what it shows if they build in these other pieces and do that effectively.
I think those are excellent examples, Stuart, that you brought up of where this coordination can really work well, and to involve trusted partners and think of this as not just in the design of a detail, but in the implementation. So of course, economists think about, you design the policy and it will have an impact. But being in a public affairs school, I have been just humbled by the importance of implementation details that my public administration colleagues study. And so again, getting back to the details, we can look at some past examples of where there were good intentions, and then things don't necessarily work out because of things we now know better to watch out for. So in 2007, West Virginia, in its Mountain Health Choices redesign of Medicaid, tried this a strategy to facing, at that time they had really high emergency department utilization rates, and thought that, well, we could design this incentive system so that there's a more generous set of benefits. It's not that you default to being kicked off insurance, but you get into the default or more generous benefits depending on whether you complete a personal health assessment plan with the provider home. And that in work we published looking at the data, actually it ended up with people having more emergency department use afterwards because of the design of those details. The generous plan had more prescription drug access. The default had very little prescription drug access. And so people lost their, who couldn't figure out how to get transportation to go take advantage of these things. So I think if we have a way of knowing that as we have implementation, we are assessing immediately. And that's where the data limitations are, right? Do we have systems in place that can tell us real time? Are there going to be dashboards so that we can, we noticed this in the data only years afterwards, because how difficult it was even then to get access to Medicaid claims data and to process this. So if there can be real-time monitoring, a commitment to saying, if we see something's not working, we're going to not feel afraid to get that feature out. I think that would really help.
Yeah, that's an incredibly important point. I have to say that's a heck of a reach for even the best organized state if it's up to the states. Again, speaking from my Maryland experience, we have tremendous access to data. We have tremendous cooperation really across the health system. But the reality is that we're always at least 6 months behind on really understanding a little bit about what's going on, and usually longer. And that's not even dealing with the sort of the social service aspects of it, which we're barely getting into. One other, I don't know, Randy, did you want to make a comment on this?
Just wanted to piggyback on something Dr. Butler said, and something he's written about. We talk about all of these great sort of interventions on social determinants and getting people connected, with their community and with work and these types of things. One of the aspects is what Dr. Butler, you called a wrong pocket problem, meaning there's savings that accrue, to governments, federal and state governments when these types of things happen because people aren't using the services or they're getting off of, assistance. And, right now there's not a good way for states that really are pushing and innovating, or communities, to reap any of those rewards. So, gee, wouldn't it be great? And we don't have that type of situation right now, but wouldn't it be great if, there could be some shared savings, to go along with, these interventions.
Yeah, that's a really important point in terms of why coordination doesn't occur because of this wrong pocket. So, for example, you may want for a certain family to say, look, we've got to get their housing kind of organized. They've got, damp housing, they've got respiratory problems associated with that. And so who's going to do this? Well, if the Public Housing Authority is the one that spends the money, and the Medicaid program is the one that saves it, there's a disconnect. So it's really important to explore ways to share in some way. Now, the governor said that in terms of the hospitals, that as I heard him, he said that there would be a dedicated flow of funds specifically to encourage this. So in other words, the money that is spent on coordination by these hospitals is not competing with the day-to-day money that they would be spending on direct care, as I understood it. That's one way forward, to have dedicated funds to get around the wrong pocket issue. Another is these things, like I mentioned, the Maryland local management boards, is say, or children's cabinets, which I'm not sure if there's one in Arkansas, but over 50% of the states have children's cabinets. And that's a very simple idea. Get all the people in the room who are in agencies that are dealing with kids, and let's actually plan together with the governor saying, I'm interested in the end result, not in where the money comes from or who's doing it. So experimenting with a variety of ways of doing that, I think, is going to be integral to success in Arkansas. This is the kind of detail that we've all been talking about that you've got to get right. I'm very confident that there's really smart people down there who understand this. But that's part of the state level experimentation itself. I mean, you can have a federal waiver to a state, but then the state has also got to say, how can we work with the counties and the cities and the FQHCs and so on to build the detail and so that we can look at that and to measure it as we go along.
You know, one other aspect of this need, extreme need for coordination in Arkansas and really across all of the states for anything ambitious, is the need to get the other welfare agencies involved in some way. You know, it's not just a matter of a Medicaid waiver. It doesn't have to be. There can be sort of cross-program cooperative ventures there. It's possible. It's complicated to get waiver authority that combines Medicaid with other social services that receive federal dollars. But there's a challenge at the federal government level, and of course there's a gigantic challenge at the state government level, because of course these other agencies have other goals, and they may be concerned that they may not be able to meet their goals if they can't devote all of their resources to their main job. So I think that's a real challenge. Kosely, do you think this is going to work?
You know, we have a lot more hope for it now that with all the knowledge we have from the past and the technology and it's still just, it's important to keep outlining what are the things to watch out for, what are the reasons for what we're seeing as disagreement, and let's say, okay, these are issues we can tackle with finding out the evidence on.
Yeah. So maybe we could talk just a little bit about these specific targeted interventions to the several vulnerable populations. I've been mulling over and how is this really going to work? And I can see some things that could really be very promising. Some things actually that developed over the past year and a half with COVID. For example, Arkansas isn't the only state where in rural areas there is a severe lack of access to mental health services. And this is a population that is burdened by opioid addiction to a great extent. And that's driven by lots of things. But mental health services are could be an important contributing factor to beginning to get a hold on this issue. Telehealth is clearly the answer. You're not going to be able to get, or clearly part of the answer. You're not going to get highly trained mental health practitioners to move out to move away from where they live now, and you're not going to have effective care if you can only see a mental health practitioner once a month, when what you really need is a more frequent help, more frequent guidance, more frequent encouragement to do the right thing. So this does bring in what the governor said about training people to pick up some of that slack, people in the community, but I think in the end, when you really need a more sophisticated level of medical assistance, you're going to have to deal with the inadequacies, not just in the rural areas, but also in the urban areas as well. You got to find some way to get the resources and the services together with the patients who need them. Any thoughts about that?
Well, I mean, I think you're absolutely right about that in terms of, first of all, the resources have got to be there. And I think the heart of the waiver helps to begin to deal with that, both the flows of money to the community hospitals and so on. But I just want to pick up on what you said about this challenge and of people, in their actual situations. And there's lots of examples, I think, which should make us, which are really encouraging. Telehealth is a good example. It's not just a way of getting people an appointment, but it can be used, facilitated telehealth can be used to get different outcomes than you had before. At Mary Center, for example, we're using telehealth as the first contact with newly pregnant immigrant women. Now, these are women who have had little or no contact with the health system at all in the United States. And they're very reluctant and hesitant about using it. So what do? You get a trusted local community health worker, or even a next door neighbor, to be with that person. And their first contact with the healthcare system is by telemedicine. They see the doc or the nurse, maybe 100 miles away. And it begins to get them comfortable with that system. And so the results of that in terms of birth weights and improved conditions and so on is tremendous, because you're getting people right at the very beginning. I think looking at intermediaries, black barber shops around the country have been used extensively as ways of being trusted agents. You go there, everybody's talking and it's comfortable. And what they do is to credential the health workers. In other words, because your barber says, Joe's a good guy and he knows a lot about healthcare, that is what induces the person to make that first contact, right? So that's the kind of thing that you can do. Southwest Virginia, many years ago, experimented with using local pastors and training them both to identify certain mental health conditions, and to be, again, the credentialer to say, well, you ought to talk to so-and-so about this, and I'll set up the meeting for you, and so on, to get people kind of comfortable about doing that. In many ways is the biggest issue facing people. It's not that the facilities are not available, but even if they are, people don't use them, and so using those local institutions, and that's, I think, in Arkansas, like other states, in the rural communities, in the urban communities, those organizations are there. And so it's important to work with them, to train them, to get their trust. And then you get the trust of the people to get the services they need across the spectrum, social services, as well as health services.
So I guess you're saying, Stuart, that the old expression, I'm from the government, I'm here to help you,
probably not the best approach.
Doesn't work that well.
Or here's a pamphlet telling you this is what you should do, and here's a number to call. That's not what works. It's been my experience over and over again.
Absolutely. We're beginning to run out of time a little bit here, so maybe we should turn to kind of some broader perspectives on Medicaid and social determinants of health. Medicaid is really in many ways well positioned, at least in terms of their clientele, their beneficiaries. They're well positioned to kind of take on a broader role. Medicaid, I think the original view of Medicaid back in the 60s and probably continuing on for some years was this is a health program, and I think over the years it's become more clear, really, to everybody, and I think it's been really quite clear to people in poor neighborhoods that there's a lot more to it than that. Fortunately, we're seeing more and more that both policymakers and practitioners in the Medicaid area recognize that there is more they can do and there's more they should do, not just because if you begin to ameliorate some of these problems, you save some money for the Medicaid program or for the health sector, but more broadly, over a longer period of time, you're potentially giving a population that has not had opportunities in the past some hope for not just economic advancement, but personal advancement, personal improvement. Have a better life. That's the goal that we all really want for ourselves. And here's a program that could potentially make a dent in that for a disadvantaged population. So I guess the kind of the general lead-in on this is how much emphasis should state Medicaid programs place on social determinants on health versus direct medical care, and it's not just emphasis, but how do they go about it, and when will we see results? There's a question.
I certainly don't have an answer right off the bat for when are we going to suggest that's how we do it. It's such a big question, though. So just to emphasize what you said, Joe, in 1965, this was added as we're giving cash assistance, and let's also give you a little bit of medical assistance through this card. And now, of course, we're spending far more through Medicaid than on cash assistance. We've expanded Medicaid while reducing the role of the cash assistance programs. And so we really have to think about this as our main vehicle for reaching populations where we can have huge impacts on health in ways that, we really can't just think of it as we'll be able to cut costs by thinking about reducing reimbursements or any other sort of ways we might in budgetary situations think about needing to, contain spending, because it's costly in so many other ways, right? So it's really just something we squeezing the balloon on one side. So what are the things that might help? Again, knowing none of these are immediately program cost savings, is thinking about how we're gonna, maybe it's the federal match rate for even the non-expansion populations being put at a level that states don't grapple so much with, we're making these choices between Medicaid and anything else, and every state knows Medicaid's just taking up so much of their budget. Is it something to be dealt with at a federal level? How do we try and take this view of what Medicaid is doing is going to be saving the state in many other ways, things that are going to be part of costs otherwise? So I think, again, no, I don't have any great answers here, just bringing up the obvious fact that this is the program to focus on for.
Yeah. So I think one of the things that the governor said, and I think it really relates to this point very well, is the idea that states should have the flexibility to experiment, not just because we're not really sure what the best approach is, but because the best approach is going to be a different best approach in many different circumstances. And so there's a question in my mind about how much flexibility the federal government will allow the states, and how much flexibility the states are willing to take to learn from their, I don't want to call them their own mistakes. They're not really mistakes. They're well-intentioned ideas that didn't work out for some reason or other. And to what extent are the things that didn't work a factor that could be ameliorated? And to what extent are the things that did work result of factors that cannot be replicated, such as I forget what the phrase is. Is it the Messiah effect or whatever it is? The leader, the community leader that makes it happen. And when that community leader moves on, the program basically collapses. Yeah. And so to me, the question is how much flexibility and are we capable of having the long view?
Well, I think there's like two levels of flexibility involved here from what you said. I mean, one is the degree to which the federal government gives a state like Arkansas flexibility in terms of how it uses Medicaid and allocates the funds and so forth. That's one level. Then the second level is within the state, kind of what flexibility and experimentation they were willing to conduct. And again, my experience is that you've really got to examine very carefully what these results are. There's a very important data component to all of this. Social determinants of health, which is the area I really work in, we have to admit that the evidence, the really good studies are pretty there aren't as many of them as we would hope. A lot of this is on faith right now, rather than hard data. So it's really important that the state, I think, builds out this waiver by going to its institutions of higher learning and other institutions and say, help us measure this so that we get a better picture, including the long-term effects. I mean, we learned with early childhood education. I mean, there was great. I mean, Head Start saying, focus on this because the results are going to be kids in pre-K and first grade are going to do really well. Well, it turned out that wasn't the case, but it turned out that there was bigger effects later on in certain areas. So it's really important to combine this local flexibility that I hope the state gives with a very careful analysis of what the results really are to build up a case over time, including the case internally within the state, to push bureaucrats and politicians to be willing to build on initial successes or uncertainties, as you said, Joe, where it's not that it's a failure, it's not working quite the way we imagined, and to understand what it is. That's really going to be very important in all of this, in addition to what the federal government's going to require at the basic level of is this budget neutral and so forth. That's one level, but these more micro levels of data are going to be really important to help the state understand what it is learning as it's going along.
Absolutely.
Yeah.
We have a couple of questions, so maybe I could raise them. The first question is from Stuart Portman of the Senate Finance Committee, and he asks, how could care coordination efforts by health plans and case management by hospitals work in concert to improve health outcomes? And then kind of a second question, but related, is it important to have accountability for connecting Medicaid beneficiaries to social supports in a similar way as for health outcomes?
I think that's a great question because it's about how do we use the design, particularly payment policy, because we know money is a great motivator for getting these systems in place. Should we be thinking about more outcomes than just health vitals? What are the things by which we're going to judge the success? So it's about, yes, it's going to mean more monitoring, more data collection, but if it can be done to show that there is the social determinants are also improving, because we know that even if it's, down the line, there will be health improvements from those outcomes. I think that's an important part to figure out how that builds into data collection and tying to payment.
And I think it's really important too that it's part of people's job description and the way they are held to account if they do this or not. I think the children's cabinets that I mentioned earlier and others work because, and the local management boards in Maryland work to a significant degree because the governors have said, I want this done, and you are going to be held to account as to whether you do it. It's part of your job description. If it's not part of somebody's job description,
Right.
They got plenty of other things to do to get their merit points, for their promotions and so on. So that's got to be part of this whole process of building that in. So I think the question is absolutely right in terms of focusing on is how do you get this to happen? This is understanding the way bureaucracies work. As Kasadi said, it's understanding the way in which systems work and people see their incentives as part of that system that you've got to really understand and tweak in order to get the effort to be put in. And then you've got to have the measurement systems to say, now they've put the effort in, let's see what the results are. And let's use that to guide our fine tuning of everybody's, future job requirement and set of activities. That's the hard work, that's meticulous work that if this waiver goes through, that's what then has to begin in Arkansas. And the governor has a very important role in setting the whole tone. If the governor, as he clearly did today, says, this is the way we're going, this is the reason, this is in line with our whole philosophy of government, and you guys further down are going to be judged on whether you're on the team in terms of doing this. That's what's going to make it happen.
Yeah, and there's this, I think the question, was about this underlying tie between payer, provider, and then, the good that we're trying to accomplish, and making people's lives better. And, talk about data. I mean, just one thing, when you think about an insurance claim, right now, insurance claims that the providers send to the insurance companies, they don't even measure anything having to do with outcomes. It's just, discharge status and what was the service provided. We could just start with collecting information on outcomes and having that information sent to the payer. And in a lot of states, this, public information with all payer claims databases and so on. But, there's just simple things that we aren't doing, I think, as a society to sort of create that nexus between the payer and the provider in addressing these issues.
Thank you. And then we have another question from Patrick, who says, asks, should this waiver, if this waiver is approved, then what is the likelihood that other states would adopt a similar approach? And he's making the point here that most other states have really adopted a Medicaid managed care model. And I guess I would argue that it's sort of an accident of the Arkansas private insurance market that has driven Arkansas to this point. But there's also an aspect of this, a financial aspect of this, a choice aspect of this, a provider, an access to provider aspect of this that potentially has some attraction, but also has some major challenges. So what do we think? Is this something that states might gravitate to?
There might also be a political aspect to this that in theory, we could be talking about Medicaid managed care and incentivizing ways to incorporate social determinants into Medicaid managed care, whether we talk about the involvement of private government entities this way or that. That doesn't seem like in theory matters, but in practice it might. And so this may open up more doors for states that did not expand so far to consider through the exchanges. So that's I think a hopeful element that arises from this, of seeing success in this way.
Yeah, I agree with that very much. And as I said at the very beginning, I think these states that have not chosen to expand Medicaid are going to be watching Arkansas to see if there's a way of doing that and then sort of cloaking it with another name and say it's not really Medicaid. But to go down that route, I think that's going to be really important. And I think the other thing to be maybe aware of, there are going to be a lot of actually liberal states that are going to be watching this too. Because I think, there's an intense interest in social determinants of health and how that fits into not just the Medicaid population, but especially the Medicaid population. And so I think there are going to be people with, in disguise coming down from, New York and other places to see what's going on there, not wanting to know people to know they're in the state of Arkansas, to sort of really see what's going on. Because I think that if this is successful, some of these ideas will be imported into other states. And again, not just conservative Republican states, but those too.
I agree. And so for some of those conservative Republican states, I think, they could take a piece of this, and then maybe also focus on some of the small group market, incentives I was talking about before, and put together something that's fiscally sustainable for their state. And it gives them more control. You're not ceding all of your authority and control over to the federal government for the future of your state budget, right? Which is what, this comes down to for a lot of states. They want to spend money on transportation and schools, but, they're being told by the federal government, well, it's got to be healthcare. So, I think, especially if you look at this as a starting point, which I think that's all it's intended to be, there are lots of other things that can follow on that could be, I think really important to a lot of states.
Yeah, and of course the governor is head of the NGA, as you mentioned at the very beginning, and the staff of the NGA is very open to a lot of this. The coordination area, maybe not some of the aspects of the Arkansas approach, but certainly many of them. NGA staff are very interested in. There's a lot of opportunity to showcase them through the NGA. So I hope I'm pretty confident that Governor Hutchinson will is very aware of that and will use that. And I think that's really good to enable other states to really understand what they're doing in terms of, at the micro level as well as the larger level. And so I think you could see a lot of copying.
So I think what we're concluding is that this is an evolving issue, not just for Arkansas, but for the country. And that could be a very, very good thing for, certainly from the standpoint of poverty populations and underserved populations, but also potentially for the health system. It's been a very dispiriting year for healthcare providers, and it's not just because of COVID, but because of the inability to solve the problems that they see in front of them every day. This is not a new thing. This is pretty standard, especially for those providers that deal with a low-income population. So I see this as potentially evolving in a lot of different ways, and I think this is a very positive kind of way of thinking about the place of Medicaid in the broader context of health and social services. Well, with that, I think we've about run out of time. Thank you again, my wonderful panelists, for being so generous with your time and for dressing up appropriately. I appreciate that. And thanks also to the governor, and thanks to our audience for hanging with us. This has been an interesting and provocative discussion, and there will be more on this general topic in the future. Thanks again.